Hello, I am Dr. Paul Blumenthal, Global Medical Director for Population Services International and Professor of Obstetrics and Gynecology at Stanford University in the USA. At PSI, we are committed to the highest quality of care for our clients. As part of that effort, we have developed this informational film aimed at the prevention, diagnosis, and management of complications and adverse events related to intrauterine contraceptive device services. This is not a training film, but rather a management tool designed to improve practice and enhance the quality of care for our clients. We hope you enjoy it and find it helpful.
Hello and welcome to all doctors, nurses and midwives who provide IUD services. I am Dr. Jyoti Vajpayee from Population Services International. We all know that complications that occur after IUD insertions are rare, but when they occur, we need to treat them and diagnose them promptly and efficiently to prevent adverse effects on clients. Through this presentation today, we will walk you through a very systematic approach on how to manage complications and adverse events that may occur after IUD insertions.
The intrauterine contraceptive device, IUCD, or sometimes just referred to as IUD, is one of the most effective methods of contraception. IUDs are very popular in China and many other Asian countries including Mongolia, North Korea, Taiwan and Vietnam. They're also very popular in Latin American countries such as Cuba and Mexico, and also in several countries of the Near East and North Africa. Among more developed countries, the IUD is the most popular method of birth control in East Europe, Central Asia, Finland and Norway. First of all, let's review some technical details about this method of contraception. The copper-containing or medicated IUD is a highly effective, long-acting reversible method of birth control and can be used as an alternative to permanent methods. It does not have any hormonal side effects, nor does it affect the quality and quantity of milk in lactating mothers. With an IUD, a woman can continue to have intercourse safely and can leave behind the stress of remembering a daily tablet. Since there is no danger of forgetting to take a pill or get an injection, some people call the IUD a forgettable family planning method. Furthermore, fertility returns the day it is removed. Although the IUD is a very safe method of family planning, side effects can occur. The side effects of the copper IUD may be unpleasant or inconvenient, but are not harmful, and in most women they subside within 3 to 6 months after insertion. Some women may experience pain, cramping, and minor bleeding on insertion, but in most cases this goes away within an hour after insertion. Heavier and longer menstrual periods are possible in the first few months after insertion, and this can be accompanied by increased menstrual cramping and intermenstrual bleeding or spotting. But this usually improves after a few months. Now let's talk about menstrual irregularities. The kind of changes in menstrual bleeding patterns mentioned a moment ago is a common side effect among women using copper-bearing IUDs. As mentioned, these changes are usually not harmful to the client and diminish within the first few months after IUD insertion. However, if bleeding lasts twice as long or is twice as heavy as usual, it is a warning sign and indicates the need for the client to be seen by a provider at a minimum and maybe a possible need for immediate management. The next thing we should speak about is cramps or pain during menstruation. Increased cramping or pain associated with menstruation is another common side effect. If these symptoms are severe or associated with other signs and symptoms that suggest they are not related to menstruation, a speculum and bimanual exam should be performed to check for underlying conditions that may cause cramping, such as pelvic infection, partial expulsion, uterine perforation, and intrauterine or ectopic pregnancy. As I said before, the IUD is a very safe method of contraception. However, even though they are rare, complications can arise. Spontaneous expulsion may occur in 2 to 8% of insertions, infection following IUD insertion in less than 1% insertions, pregnancy in less than 1% insertions, and perforations in 0.15 to 0.2% insertions. For providers, it is important to know that the small amount of complication exists even when the procedure is properly performed by a qualified clinician following all protocols and guidelines. Complications can be potentially life-threatening and could have long-term health risks if not identified and treated. It is therefore important for a trained medical service provider to be able to provide effective assessment and management. Providers should be able to recognize these signs so that complications can be identified at the earliest, limiting their ill effect on the client and perhaps avoiding an adverse event.
Before going any further, let us discuss the difference between a complication and an adverse event.
Complications are uncommon outcomes resulting from a procedure or treatment. Complications associated with inserting the IUD are rare but possible. Complications that need immediate assessment or management include pregnancy with IUD, missing strings, perforation, expulsion, partial expulsion, or infection. Missing strings may also be a sign of perforation. If complications are not properly managed, they can become an adverse event. Adverse events are defined in a specific way and are determined by one or more of several outcomes. 1. Unintended major surgery. 2. Blood loss requiring transfusion. 3. Admission to the hospital for intravenous antibiotics or other inpatient treatment. Or 4. Death.
There are usually some warning signs that should alert a trained medical provider that something is wrong. And these are what we are going to discuss today. So what are these warning signs? Well, it's very easy to remember. It's an acronym, PAINS. P-A-I-N-S, PAINS.
P stands for period-related problems. When a client comes to you complaining of irregular or heavy bleeding or missed periods with or without symptoms of pregnancy, the very first thing that must be ruled out is a pregnancy. You must ask the client these questions. When was her last menstrual period? Does she have any other symptoms of pregnancy? After getting as much information as possible from the client, conduct a physical examination to confirm pregnancy and to rule out any other pathology. It is especially important to document whether the string is visible at the cervical os. To confirm pregnancy, perform a urine pregnancy test. If the pregnancy test is positive, then ectopic pregnancy must be ruled out. If the client complains of severe lower abdomen pain, especially if it is one-sided, it could be indicative of an ectopic pregnancy. The symptoms and signs for ectopic pregnancy are unusual abdominal pain or tenderness, abnormal vaginal bleeding, or no monthly bleeding. If available, an ultrasound should be done to determine the location of the IUD, location of the gestational sac, whether both the IUD and the pregnancy are extrauterine or intrauterine. The ultrasound should be performed by someone with skill to be able to locate the IUD or the pregnancy. If the gestational sac is extrauterine, it must be treated as an emergency medical condition, which, unless treatment with methotrexate is available, requires immediate surgery. If the pregnancy test turns strongly positive very rapidly and no pregnancy is seen in the uterus, an ectopic pregnancy may be presumed unless there is also clear evidence that a miscarriage may be in progress. In this case, depending on the client's symptoms, she may be observed for a day or two to see whether her condition improves spontaneously. If not, then surgery will be required as mentioned before. If the string is not visible and the ultrasound shows extrauterine IUD, the IUD should be removed after her delivery. If the IUD is in the uterus, the string is visible, and pregnancy is of less than 12 weeks, it is recommended that the IUD be removed, but the client must be first counseled regarding a slightly increased risk of miscarriage. She should also be informed that with the IUD in place, she has an increased risk of a preterm delivery or miscarriage, including septic miscarriage during the first or even the second trimester. This may be life-threatening to her. If the IUD is in the uterus but the client does not want it removed, or the string is not visible, or the IUD cannot be safely retrieved after an attempt, then inform her that her pregnancy will require close monitoring by a doctor or a nurse midwife, and she must come to them immediately if she develops vaginal bleeding, cramping, pain, abnormal vaginal discharge, or fever. If the IUD is in the uterus and the string is visible and pregnancy is of more than 12 weeks, do not remove the IUD and counsel the client regarding slightly increased risk of miscarriage and infection. As in the previous case, her pregnancy should be closely monitored by a doctor or a nurse midwife, and she must come to them immediately if she develops vaginal bleeding, cramping, pain, abnormal vaginal discharge, or fever.
A stands for abdominal pain. The client may complain of persistent, unexplained, or even excessive abdominal pain. In such cases, pelvic infection, partial expulsion of the IUD or dislodgement of the IUD, pregnancy, and even uterine perforation must be ruled out. Perform a thorough physical examination and appropriate investigations to arrive at an accurate diagnosis.
If the IUD is partially expelled, remove it by using an artery forceps and insert a new one immediately if the client desires it and insertion is safe. If she does not want to continue using an IUD, but at the same time does not want to get pregnant, provide an alternative method if possible, as well as a backup method if needed. I stands for infection. When a client complains of purulent or foul-smelling discharge, infection is a diagnostic possibility. This may or may not be associated with lower abdominal pain, painful intercourse, pain during urination, bleeding after sex, or between periods or menstrual pain. If the symptom of pain was absent during the first few months after IUD insertion but has now developed, this is indicative of an infection. A thorough physical examination should confirm the diagnosis. If infection is not severe and the client's general condition is stable, treat the infection by prescribing a suitable antibiotic. For sexually transmitted infections such as gonorrhea or chlamydia, the client should be treated and the couple urged to use condoms. The client can continue using the IUD unless her symptoms do not improve within 72 hours. However, if she wants the IUD removed, take it out 2 to 3 days after the antibiotic treatment has been started and provide alternative contraceptive options. If the infection is severe, characterized by signs of peritoneal irritation, a fever over 38.5 degrees Celsius or a rapid pulse, hospitalize the client to treat with IV antibiotics and IV fluids if required. N stands for not feeling well. When a client comes with fever or without chills, it indicates infection, especially if the client doesn't exhibit any other signs of flu, fever, or an upper respiratory infection.
So let us come back to the acronym. S stands for string problems. Missing strings, shorter strings, or longer strings may indicate a number of potential IUD complications. And these include expulsion, dislodgement of the IUD, pregnancy, or maybe the IUD is in place and the strings are missing, and uterine perforation. In cases of missing string, the very first thing to exclude is expulsion and then pregnancy. The client must be asked these questions. When was the last menstrual period? Does she have any symptoms of pregnancy? Did she see the expelled IUD herself?
Only after pregnancy has been ruled out, confirm the position of the IUD by an X-ray and ultrasound of the abdomen and pelvis. Ideally, the X-ray is performed with a radio-opaque instrument such as a uterine sound placed in the uterus so that the location of the uterine cavity can be documented relative to the IUD visualized on the radiograph. In this X-ray, we can see that the uterine sound is in the uterus and the IUD is lying away from the uterine sound at a distance. This clearly indicates that the IUD is not in the uterus but lying outside the uterine cavity, and it is a case of perforation. In cases where there is doubt in the X-ray or ultrasound whether the IUD is extrauterine or intrauterine, it is recommended to take the help of the uterine sound. Complete expulsion can occur unnoticed. X-ray findings help to confirm that the IUD is neither in the abdominal cavity nor in the uterus. If there is no infection and the client wants an IUD, insert a new IUD. If she does not desire an IUD, provide an alternative method, as well as a backup method if needed. If the IUD is still in the uterus as seen in the X-ray or ultrasound, but the strings are missing, they may be high up in the vagina or the cervical canal, or may just be broken. Probe the cervical canal gently with a sterile cotton swab stick or cytobrush. Check for the strings in the folds of the cervical canal. If the strings are located and drawn out, and it seems that the IUD is properly placed, and if the woman wants to keep the IUD, leave it in place. If the strings are located and drawn out, and the woman does not want to keep the IUD, remove the IUD. If the strings have not been located and the IUD is in the uterus, the client should be counseled to continue with the method. In case she insists on having the IUD removed, it should be removed with the help of the alligator or the Borsman forceps. Care should be taken to not injure the uterus while ensuring the client's comfort. Cervical dilation is sometimes required. An oral analgesic can be prescribed, which will help decrease the discomfort associated with the procedure. When probing the uterus with an alligator or Borsman forceps, it is very important to make slow, deliberate, and gentle movements within the uterine cavity. Subtle open and close movements of the instrument's jaws while gently rotating or moving the instrument back and forth may reveal the presence of the IUD by feeling the instrument rub against it. If this occurs, then the instrument can be opened and closed while pulling towards the cervix. If resistance is felt and the sense that there is something in the instrument's jaws, then the IUD has likely been grasped and can be removed. If there is a failure to locate the IUD, its presence in the uterus should be reconfirmed with an X-ray or an ultrasound. The client is then counselled to continue with the IUD and return for a follow-up during her menses or after 4 weeks. If the X-ray finding confirms that the IUD is outside the uterus in the abdominal cavity, it is a case of complete uterine perforation. In such cases, the client must be counselled, hospitalized, and the IUD removed by an experienced service provider. This should be done through laparoscopy under local or general anesthesia.
Once you've diagnosed that the IUD has perforated the uterus and is lying in the abdominal cavity, it is important to remove it. And the best way to remove it is by laparoscopy. For this, you require a facility which has got laparoscopic instruments, and you require a trained laparoscopic surgeons. Once we are inside the peritoneal cavity and we are trying to locate exactly where the IUD has perforated, here we are. We've lifted up the uterus and we're gently trying to now pull it out in the direction of least resistance. We've got the T of the IUD. We're going to hold it now. This time we're going to use a traumatic grasper so that we have a good grip. Hold the T, and once we've held it, you gently tug it out.
When the IUCD is complete perforates the uterus and the instrument for laparoscopy is not present, the IUCD should be removed by main laparotomy from the abdomen.
We are taking a suprapubic incision of about 2.5 centimeters or 1 inch. We have now opened the abdomen and will start locating the IUCD and gradually withdraw it from the abdomen under direct vision. We will now go ahead with the procedure of a mini-lap tubal ligation. We will check the hemostasis on both the sides and proceed with closure of the abdomen.
If the perforation is partial and the IUD is stuck in the wall of the uterus or the cervix, a hysteroscope for IUD removal may be used.
There are certain situations in which the thread of the IUD is not seen on speculum examination. When a situation like this arises, an artery forceps can be introduced under direct vision to remove the IUD that has been placed in the endometrial cavity. A full bladder ultrasound also can be done to aid removal of this IUD. When both these methods fail, we perform a hysteroscopy to locate the IUD and remove the IUD under direct visualization. When a decision has been taken to remove the IUD using a hysteroscope, there are certain specialized instruments that are required before the hysteroscopy is performed. Once the cervix is dilated, the diagnostic sheath along with the hysteroscope is inserted into the uterine cavity. The IUD is located, as you can see, it is embedded inside the uterine cavity. The placement of the IUCD is confirmed on a diagnostic sheath. The grasping forceps, as you can see, is then inserted through the operative sheath. The IUD held firmly with the grasping forceps. Once the IUD is held well with the grasping forceps, the IUD is removed out of the uterine cavity under direct vision.
The client must then be counseled to choose either an alternative method of contraception, or if she is willing, an IUD can be inserted.
Uterine perforations may be silent, without any symptoms, except the missing string, which is noticed on the follow-up of a client. Alternately, the client may complain of moderate to severe lower abdominal pain, which is not relieved by any symptomatic treatment. It is very important to note that these symptoms may appear days after the IUD insertion, or weeks, or sometimes even months after the insertion. And unless a clear reason for the pain is recognized, IUD complications must be ruled out. We hope through this presentation we have provided you with safe, structured and logical approaches to management of IUD side effects and complications, all with a view of avoiding and minimizing danger and discomfort to the clients we serve. Thank you for your attention and for your commitment to high quality care.